Hello, I'm John Power, and these are some thoughts and reflections on COVID-19. I'm a registered nurse, not a biologist or an epidemiologist, but just trying to draw together some of the material and provide some degree of perspective on this infection. We're told that COVID-19 first appears in November or December 2019. Initially thought to have emerged from a cross-contamination within a live animal food market in Wuhan, China. This analysis was quickly adopted and endorsed by the WHO, that's the World Health Organization. More recently, however, concern was raised about research undertaken at the Wuhan Center for Disease Control, and that's only a relatively short distance from the live animal market, and their experimentation on or with novel corona-type viruses, and indeed the horseshoe bat alleged to have been sold within the animal market. This raised the possibility, and only the possibility, of a serious, indeed catastrophic bioerror, and not actually emergent from the food market. There are a range of coronaviruses, and perhaps 20% of those suffering with the common cold have been infected by one of the group of coronaviruses. A lot of people are very frightened, and there is perhaps a disproportionate amount of fear and concern across communities, fueled sometimes by media exaggeration, speculation and spectacularization. The European Centre for Disease Management suggests a mortality rate between 1 to 2%. That is approximately 2 people in every 100 of those infected may be at risk of death. This compares with a mortality rate for, say, something like the SARS epidemic early in the 2000s, of some 10% or thereabouts. The virulence of an infection within a particular individual depends upon the viral count, and that would particularly mirror close contact for an extended period of time. In addition, the virulence of the infection experienced by an individual could depend on their general health, but particularly the health, stability and dynamic of their immune system. Some 80% of those infected experience mild to moderate symptoms, and indeed a proportion of that group are not actually aware that they have been infected. The WHO had suggested an infection rate or reproduction number, sometimes presented in the literature as R0, for each one person infected, infecting up to 2.5 others. More recently, the European Centre for Disease Prevention and Control suggests a transmission rate, or R0, of up to 4. That is for every one person infected, and assuming significant contact, they may infect up to 4 others. COVID-19 is significantly infectious. Consequently, some healthcare staff would come into extended contact with the virus. They might also be amongst the at-risk groups themselves. Their risk of significant infection could therefore be proportionately increased. Across a range of European studies, and indeed within the UK, healthcare staff have featured disproportionately, both in terms of infection rates and mortality. Again, comparatives can be misleading. However, within England alone and across the last 5 years, there has been an average mortality of about 17,000 people from influenza alone. Indeed, the influenza epidemic of 2014-2015 records deaths of just under 23,000 people. Again, that was for England alone, and those figures are drawn from Public Health England. Therefore, to hold everything in perspective, or attempt to anyway, and based on the emergent figures from studies across the European Union and China, approximately 80% or thereabouts of the population affected and infected by the virus experience no symptoms or mild to moderate symptoms. A proportion of the remaining 20% experience symptoms requiring hospitalization, and 2.4% of those hospitalized have presented with severe illness. The virus represents a mortality rate for that part of the population actually infected between 1 to 2%. There are a range of figures out there, but this is my best attempt to draw a synopsis of the figures together. Groups that are particularly at risk from the virus would include the elderly, that's 70 years and above, and particularly those over 80 years. Those with past medical histories and current disability, that's relevant past medical histories. Ethnicity appears to be an emergent issue, particularly within UK studies, with Black and Asian groups disproportionately represented, both in terms of serious illness and mortality. Those with compromised immune systems for whatever reason are disproportionately at risk. Males appear to be at higher risk than females. Importantly, one's general health can present a risk factor, including poor dietary history and management, and of course significant overweight and obesity. Importantly also to consider location, with the increased risk factor of crowded and polluted environments. Significant comorbidity, that is other significant pre-existing illnesses or disabilities, and obesity appear disproportionately in both those treated for serious illness within hospital and in mortality rates. Children represent a very small proportion of reported cases, approximately 1 to 4%. The younger the child, the closer to 1% is their statistical risk. It is important to remind ourselves that the risk of severe illness is limited. The European Centre for Disease Management and Control suggests that possibly up to 3% of those hospitalized cases present or develop severe illness, requiring respiratory support and or ventilation. But why are some people becoming really quite seriously ill and in some cases dying? Viruses, including COVID-19, infect cells. They operate within the cell. Within a significant infection, then a significant immune cascade is triggered, and this produces an inflammatory response. In these cases, predominantly within the lungs. This is a natural process within the immune system. In some individuals, and only in some individuals, the immune response is limited or relatively ineffective. This translates then to the risk of increasing viral counts, and they present with more advanced symptoms. They are at risk of becoming significantly more ill. Or in some of the more seriously ill patients, having triggered an immune response and the inflammatory process, the immune system doesn't then switch itself off or suppress the inflammatory process, as it should do. What develops then is lung tissue damage. Lung tissue flooded with dead cells, tissue fluids, and becomes progressively congested, together with ongoing tissue damage resulting from an autoimmune type of response. This can then translate to increasing shortness of breath, and if this progresses, then can present as what's referred to as acute respiratory distress syndrome, or indeed sepsis. This can certainly be very life-threatening. However, important to remember that this process is not necessarily the infection. In some cases, it is an unstable immune response to the infection. Therefore, an early focus should be on building, enhancing, and stabilizing our metabolism and immune responses before we become ill. What can we learn then? What can we learn? David Heyman, previously of the World Health Organization and former chair of Public Health England, emphasizes, amongst other things, the need to take care and treat with more caution the animal-human interface, particularly the increased intensification of animal husbandry and the significant risk and hazard attaching to that. It is very important to determine the actual origins of this desperately damaging corona variant. In terms of minimizing risk then, to focus support and resources rather more on those particularly at risk. For example, those that might score, say, 2 or a maximum of 3 risk indicators on a scale of 7. We cannot necessarily alter many of the risk indicators for ourselves individually, but we can perhaps alter some of them. We could try and apply more basic health principles, particularly diet, exercise and waste management and weight management, and in the process help to enhance our immune response, thereby increasing our chances and opportunity of moving ourselves into the 80% block of the population who experience, if they are infected, mild to moderate symptoms. However, and importantly, we must hold things in perspective. Particularly and importantly, the actual risk for a very significant proportion of the population, and our potential and opportunity for reducing that risk to ourselves and to our families. Nature isn't our intrinsic enemy, and we have no need to fear it. COVID-19 is perhaps a response to the inappropriate misuse of our stewarding role in relation to nature. As we come out of this pandemic, as we will, the road lies ahead. Which direction do we take? I'm Dr. John Power, a registered nurse. I hope that this overview was of some value, and thank you for listening.